Welcome to the new series called eMED, where we present you knowledge that's worth sharing. In the first video of this series, we present you pediatric limb injuries. The objectives here would be to explain to you how to recognize the common childhood limb injuries, clinically reason out how we are going to manage these patients and why we are doing what we are doing, and always think of child safeguarding issues. Let's begin the talk with the first scenario of the day. A 5-year-old male child is in the emergency department with history of a twisted ankle injury. He complains of swelling on the lateral malleolus at the ankle and is walking with a limp. There is no history of any fever or rash. The child has no tenderness on the posterior aspect of the fibula. However, you notice a swelling with mild tenderness anteriorly to the malleolus. He is able to weight bear and walk 4 steps. Which of the following 4 options is false? I would let you think over it over a period of time and come up with an answer. Okay, so the first option was he needs an X-ray, although Ottawa ankle rule is negative on your assessment. He does not need an X-ray as Ottawa ankle rule is negative on your assessment. You should be thinking if there are any child safeguarding concerns. Growth plate fracture may impede bone growth. The importance of this question highlights 3 things over here. Whom do you image? Thinking of safeguarding concerns in a pediatric limb injury, and the importance of understanding the growth plate injuries in pediatric patients. When the Ottawa ankle rules first came in the year 1992, they had excluded a subset of population seen in the emergency department. They did not include anybody who was less than 18 years of age, someone who was intoxicated, somebody who had some major injuries, and the pregnant patients. However, recent researchers have shown that the Ottawa ankle rules are applicable in pediatric populations above age group of 2. Secondly, this scenario also highlights that thinking of safeguarding concerns while treating pediatric patients is paramount. And as we said earlier, remember, the growth plate fractures can be important in pediatric patients because as they grow, if there are any fractures to the growth plate, that may impede healing process, that may result in stunted growth. And that is why understanding the growth plate fractures will be important. Let's move on to scenario 2. Here you see a 11-year-old girl is in the emergency department, complaining of the pain in the right foot since one day after a PE lesson in the school. X-rays obtained as given in the image. Child is limping and no clinical signs of fractures are present. What would you do now? You need to enlist 3 steps of management. This scenario highlights few things. The management steps you would take in the emergency department while managing a limping child. Secondly, it also highlights why a radiograph for a pediatric patient is different than an adult. Things that may look like a fracture may not be a fracture at all, whereas things that may look to be normal may be actually a fracture. For example, the tibial spiral fracture may be normal on an X-ray. You must have heard of scivora, spinal cord injury without radiological abnormalities. I will give you a few moments to think over what would be the management steps over here, and I will tell you the answers in a bit. Let's address the steps of management in this patient. First and foremost, we'll be addressing the pain management appropriately based on their pain scores with oral paracetamols, opioids, other methods such as distraction, splinting. Second would be giving them reassurance and safety net and rise advice. Let's look at the parts of a bone. If you look at the image given over here, you will see the diaphysis, which is the shaft of a long bone. The two ends are the epiphysis, and the part which forms the growth plate is the metaphysis. Understanding the anatomy of the long bone in pediatric patients is essential because we'll be linking this knowledge to the Salter-Harris classification of the growth plate fractures in a long bone. If you look at the screen, Salter-Harris has 5 levels of injury. S stands for slipped epiphysis. A stands for above the level of epiphysis, that is involving the diaphysis. L stands for below the level of epiphysis, below the level of growth plate. T stands for through the 3 layers, including the epiphysis, growth plate, and the diaphysis. And R stands for a rammed epiphysis. Most common one is a Salter-Harris type 2, in which the fracture line goes through the diaphysis, that is above the epiphysis. And the most commonly missed one are the type 1 and the type 5. Type 1, which is slipped epiphysis, and type 5, which is a rammed epiphysis. Out of these two, the worst prognosis is from type 5, which is due to a crushed injury. This is a humorous representation of the Salter-Harris classification taken from medcomic.com. One of my trainees, when I was using this slide, asked me, "Why is that fellow laughing?" And I asked, "Which one?" He said, "Number 2. Although the bone is broken, he's laughing. I'll tell you the reason behind it. And it is because he's the most common one. And look at type 5. That's the type of crush injury. He's in a lot of pain, commonly missed with the worst prognosis." Next, we move on to something called as traction apophysitis. So, as the child is growing, you have the tendons pulling the bones. Remember one thing over here, I'll give you a pearl. In children, the ligaments are stronger, the bone is developing. Therefore, bone tend to break quite often. So therefore, have a low threshold while requesting imaging for these children. This long tendon keeps giving traction on its attachment to the bone, leading to avulsion at that particular attachment. This together is known as traction apophysitis. You will see commonly in the adolescent when they are doing the high risk activities, they are most energetic, they have hormonal changes, they will come in with limp. And if you examine their knee, the knee appears normal. However, you do the x-rays and x-ray shows an avulsion fracture. It is not a fracture, it is an avulsion at the insertion of those ligaments. And there are some names attached to them which we should know and are commonly tested in the exams as well. The 3 common ones of traction apophysitis are Osgood-Schlatter disease, Sinding-Larson's disease, and Sever's disease. If you look at the 2 x-rays over here, you can easily point out to the first one on the right of the screen as there is an avulsion fracture. However, clinically when you examine this child, he's not in distress, not in pain, there's no significant injury, and he's able to weight bear. And that is commonly seen in boys more in boys than in girls in the adolescent age group. And that is a traction apophysitis of the tibial tuberosity, commonly called as Osgood-Schlatter disease. In the second image, if you see at the lower pole of the patella, where the origin of patella ligament is there is some avulsion over there because of the constant traction, and that is called as Sinding-Larson's disease. In this image, if you see at the lower part of the calcaneum, there is an avulsion deformity, and that is called as Sever's disease. Here is the attachment of the calcaneal ligament. What is the treatment for this? What would you do? The treatment is just price, which is paracetamol or ibuprofen, rest, ice compressions, elevation of the limb, and compression bandages. Reassurance will be important to the parents, and safety net advice should be given. In relation to the Osgood-Schlatter disease, we will talk about something similar to it but significantly serious and needs surgical management. We'll come to that in the coming slides. So if you look at this image, this is a 14-year-old boy who comes in with significant pain after a sprinting exercise. He's unable to weight bear. There's gross swelling in the anterior part of the leg and some swelling in the mid-leg portion area as well. The child is in significant pain and you will have classical findings of a fracture. However, if you look at the x-rays closely, the x-ray seems to be like that of an Osgood-Schlatter. However, here there is an avulsion fracture of the tibial tuberosity, and one has to bear in mind there is a recurrent anterior tibial artery which goes around from there, and with this fracture, that artery, the RATA, recurrent anterior tibial artery, can get avulsed in about 4 to 10% of patients and can give rise to something called as compartment syndrome. These patients need to be referred to the orthopedic team for surgical fixation. Let's move on to the foot. What do you see here? You see a line or a chip of bone at the base of fifth metatarsal. This is not a fracture. The child may not be in significant pain and there will be no significant clinical findings of a fracture here. This is an ossification center which will heal, commonly seen in the age group 10 to 13, and this should be conservatively managed. Let's look at this image over here. In this image, you see a linear line going through the base of fifth metatarsal up at the level of syndesmosis, and such fractures are called as Jones fracture. Any fracture line going below the level of syndesmosis is a pseudo-Jones, and any fracture above the syndesmosis or distal to the syndesmosis is a stress fracture. Let's move on to CRITOE. You must have heard about this. If not, we will learn about it today. CRITOE is a mnemonic to understand the ossification centers at the elbow. C stands for capitulum, R stands for radial head, I for inner epicondyle, T for trochlea, O for olecranon, E for external epicondyle. Normally, these start at 6 months to a year and are in the same order 1, 3, 5, 7, 9, 11. The importance is not that of the age, but the order over here. So what I mean to say by that is, if trochlea is present, capitulum, radial head, inner epicondyle should be present. If external epicondyle is present, the remaining 5 should be present. If any of them is missing, then you're going to look closely for a fracture or consider advanced imaging, obtaining opinions from the orthopedic team. Let's look at some images over here. What do you think? Is this normal or abnormal? I see the capitulum. I see the radial head. I don't see the inner epicondyle. I see the olecranon, and this is the trochlea, and I see the outer epicondyle. This is missing, and if you look closely, this is gone into the elbow joint just above the ulna. So this is an abnormal X-ray. There is a very good video to watch on YouTube, and I would consider I'll put the links down in the description below so that you guys can go and watch that video to get a better understanding of the CRITOE. What are we looking at? We are looking at something which is opposite to child abuse. This is child love. The parents are happy, pulling the child by their arms, giving them a nice ride, showing their tender loving and care. But they don't recognize that what they're doing is not safe for a growing child. If you give a pull to the child's arm, there's a tendency of the child's radial head to sublux out of the annular ligament, and that is called as a pulled elbow. Do you see this elbow in the image? You will classically see the child keeping one arm on its side, not allowing anybody to touch it, not moving it, while the child is undisturbed, is quite happy, will be moving the other arm and interacting normally. However, the child keeps the affected arm in a steady position, not allowing anybody to touch it. There may be variable amount of history given. The parents may say they were holding the child, they were getting the child out of their car, or the child put the hand below a table or a bench and started crying, or they may just say we do not know what's happened. However, this presentation is quite classically to move, not allowing anybody to touch that elbow, and you're going to go there and do the reduction and be the magician in that child and the parent's life by reducing it with a click. There are two techniques commonly used. One is supination and flexion. What you do is you go and flex the child's arm, elbow, and supinate it. The other thing is you flex and hyperpronate it. At that point of time, your hand will be at the child's radial head and you may feel a click. Once it is done, you can allow the child to play in the play area for 10 to 15 minutes. Go back and reassess. The child will be happily moving it. If they are not moving, consider alternate diagnosis. Get imaging done and may need an arm sling or a fracture clinic review. Let's go to supracondylar fractures. Supracondylar fractures are quite common in the emergency department. The child will come with a history of a fall on outstretched hand. You need to check the neurovascular status of the limb distally, and few things will be important over here which we'll talk about, called as sales and fat sign, lines, and when do we do reference. If you look at this image, you see a triangular shaped shadow in the anterior part of the distal humerus, looking like a sail. That is a sail sign. Normally, little amount of fat pad is seen in the anterior part, but a classical sail sign may be obvious in a supracondylar fracture. With the next image, you see two fat men. One has a big belly and one has fat at the back. So which one is more pathological? Having fat in the front or having fat at the back? So fat in the front may be considered normal. It's a part of obesity. But fat at the back demonstrates a pathological process called Cushing's. So here we come and see a fat pad sign on the posterior aspect. A fat pad sign on the posterior aspect is always pathological, and is diagnostic of a supracondylar fracture. You will be lucky if you see a sail sign. However, that is not there always. But a posterior fat pad sign means there is a supracondylar fracture. You can draw lines in front of the humerus going through the capitulum, called as humerocapitular line or antehumeral line. Why I'm talking about supracondylar fracture today is because you fall on outstretched hand and bam, the brachial artery is gone, The median nerve is gone. Possibly the radial nerve is also affected. That is why it's so important to check the neurovascular status. The question is, when do you refer these patients to the orthopedic in emergency so that a surgical fixation is done? When there is gross displacement, more than 50% displacement, or gross angulation, 20% posteriorly or 10% sideways, or if there is an obvious distal neurovascular compromise or in an open fracture, you would like to the orthopedic consultant team to come and review this child. Other than that, if these things are not seen, you can safely discharge the child with an arm sling or a plaster cast and follow up with a fracture clinic. Let's go to some other common injuries. Torus fracture or buccal fracture and a green stick fracture. These two are different. A torus fracture is due to an axial force. A torus fracture is due to an axial force and you see bulging of the cortex. What you do in this case is splint them, offer them the price advice and safety net advice, reassure them and get them followed up in the fracture clinic if necessary. Whereas a green stick fracture is fracture of one cortex. And this is managed on the same lines as a torus fracture. You will see a bulging cortex or a broken cortex only on one side of the bone. Let's come to something which is one of my favorites called toddler's fracture. So this is quite commonly seen in the age group 1 to 4. A rotational force at the tibia causing a spiral fracture. The child may revert back to crawling. So he's learned how to walk and now he's started to crawl because he can't weight bear on that. When you do an X-ray, you will see a normal X-ray. Remember when I said there may be a pathology whereas radiologically they may be normal, like scivora and spiral fractures of the tibia. You need to clinically diagnose this condition. I always consider a toddler's fracture synonymous to scaphoid fracture in the adults. A fracture may not be obvious and there may be signs of a fracture over there. This patient needs a long leg cast, a X-ray repeated in 10 to 14 days, and a follow-up with the orthopedic team. To end this session, I've added an X-ray as a bonus and another condition which we have to be aware of. This X-ray, if you look closely, the head of the femur has been slipped on the left side. This is classically seen between the age group 10 to 14, 15. Classically, the child is obese, have small genitalia, or if he is of normal weight, he will have normal genitalia. This is the way they frame in the exam. You take an AP view and a lateral view. If that is not clear, do a frog leg view. It will be obvious on examination. The pain may be referred to the knee, so the child may come limping with knee pain. So get an X-ray of the hip to rule out a slipped capital femoral epiphysis. The orthopedic surgeon has to be involved over here and they would likely fix it by surgery. It is usually bilateral. Even if it is not bilateral, the orthopedic surgeon might prophylactically fix the other hip as well. Let's move on to the next one. Here I have put up a criteria called Kocher's criteria. This criteria is used in an unwell looking septic child with joint swelling or inflammation, or a limping septic child. Think of this criteria with your clinical acumen and consider the diagnosis of septic arthritis. If two of these criteria are fulfilled, there is 40% chance that the child has septic arthritis. Staphylococcus aureus is the most common organism over here. So remember, fever greater than 38.5, ESR greater than 40, white cells greater than 12, and unable to weight bear. Two of these is 40% chance of septic arthritis. 1 or 0 is less than 3% chance of septic arthritis. With this, I wish you good luck. Wait for the next video. If you haven't subscribed me yet, please subscribe, hit the like button, pass on the comments, share this video. I will see you soon in my next video. Thank you. Welcome to this new shit. I need a script, man. However, the child keeps the affected arm in a steady position, whereas things that look like a fracture, sorry, looks okay. Stop. This light source, man. Okay, this will become a TED talk over here so that I don't move out while I'm talking. Okay.
Do you want tea?
Anil, man, don't disturb me, man. I need to finish this today. If the child is an adult, child cannot be an adult. Hey, give me the phone. Give me the phone. Why are you recording unnecessarily?